Welcome again. In the first part, we are continue with a topic of medical therapy of renal disorder. Our journey in this part, the part 2, will take us through the acute kidney injury, chronic kidney disease, and finally the end stage renal disease. Let's start by the acute kidney injury. Acute kidney injury or AKI is a sudden, rapid reduction in the glomerular filtration rate and the kidney's ability to excrete waste. It typically hits previously healthy kidney and lasts days to weeks. We categorize AKI or acute kidney injury into three causes. The first cause, pre-renal, caused by inadequate perfusion like severe dehydration, intrinsic, caused by diseases with the kidney tissue itself like acute tubular necrosis or nephrotoxicity. This is number two of the causes. Number three is post-renal, caused by urinary tract obstruction. How do we manage the acute kidney injury medically? Clinician used a blood urine nitrogen to creatinine ratio to pinpoint the damage. A ratio greater than 20 to 1 suggests pre-renal damage, while less than 10 to 1 points to intrinsic damage. The most devastating intrinsic cause is ischemic acute tubular necrosis, often resulting from shock or sepsis, which is highly catabolic. In the acute phase, patients often require hemodialysis to correct uremia and acidosis. In the ICU, the intensive care unit, patients might require continuous renal replacement therapy or CPR, CRRT or CRRT, constantly filter waste while allowing for a pre while allowing for parenteral nutrition. Nutritional management during acute kidney injury is a delicate balancing act. So, the medical nutrition therapy for acute kidney injury, the protein and energy. Nutrition in acute kidney injury is a complex because we must balance the treatment of uremia with a massive physiological stress of the tissue destruction. Regarding protein needs vary. 0.8 to 1 gram per kilogram of stable non-dialyzed patients, or 1 to 1.1 gram per kilogram if healing is required, and up to 2.5 gram per kilogram for patient on CRRT because of high dialysate protein losses. Energy should be provided 30 to 40 kilocalorie per kilogram of ideal body weight to prevent the body from breaking down its own protein or fuel, though we must avoid overfeeding, which depresses respiration by increasing the carbon dioxide production. Fluid and electrolyte require equal vigilance during acute kidney injury. For fluid and electrolyte, during the early oliguric phase of acute kidney injury, fluid intake must be meticulously balanced to equal net output urine emissions, diarrhea plus about 500 ml for insensible losses. Sodium is restricted to 20 to 40 milliequivalent per day. Potassium must be heavily uh, because damaged tissue dump massive amount of potassium into the blood. So intake is restricted for the potassium to 30 to 50 milliequivalent per day to avoid cardiac overload. Aggressive fluid removal is discouraged to protect heart from myocardial stunning. While acute kidney injury is sudden, the chronic kidney disease is slow burn. Let's look to chronic kidney disease or CKD. But before we go into chronic kidney disease, let's summarize the medical nutrition therapy for acute kidney injury. For the protein, as I mentioned before, adjust per medical doctor, per MD, for the gain of function 0.8 to 1 gram per kilogram ideal body weight. Ideal body weight increasing as the glomerular filtration rate returns to normal, but if the cause of acute kidney injury requires a protein for healing, the goal should be closer to 1 to 1.2 gram per kilogram for the ideal body weight. Regarding energy, 30 to 40 kilocalorie per kilogram for body weight. For potassium, 30 to 50 milliequivalent daily in oliguric phase, depending on the urinary output or dialysis and serum potassium levels. Replace losses in diuretic phase. For sodium, 20 to 40 milliequivalent per day in oliguric phase, depending on the urinary output and the edema, dialysis, and serum potassium level, and replace losses in a diuretic phase. Regarding fluid, replace output from the previous day, vomitus, diarrhea, urine, plus 500 ml. Lastly, phosphorus, limit as necessary. Now, we are going to discuss the second type after acute kidney injury, the chronic kidney disease or the CKD. Chronic kidney disease is characterized by a slow, steady, and often irreversible decline in renal function. The leading risk factors are diabetes, hypertension, and glomerulonephritis. We divide CKD into 5 distinct stages based on the estimated glomerular filtration rate or EGFR. A patient doesn't just have one bad lab draw. They must have consistently low for a glomerular filtration rate level below 60 across tests spaced at least 3 months apart to be diagnosed. Let's review the exact stages for the CKD or the chronic kidney disease. Chronic kidney disease stages and assessment. The staging help us predict a progression and mortality. Stage number 1, normal or high glomerular filtration rate above or 90 or above. Stage number 2, mildly decrease between 60 to 90. Stage number 3 and 3A and stage number 3B, mild or represent a mild to severe decrease spanning 30 to 59. Stage number 4 is severely decreased kidney function at 15 to 29. Stage number 5 is complete kidney failure below 15. To accurately assess this, clinical guidelines recommend pairing the glomerular filtration rate test with a urine albumin to creatinine ratio. What exactly drives a patient into these stages? Causes of chronic kidney disease. Chronic kidney disease can stem from systemic disease that affect the whole body, like diabetes, systematic infections, atherosclerosis, hypertension. It can also come from primary kidney disease, such as glomerular disease like glomerular sclerosis or interstitial diseases or genetic cystic diseases like polycystic kidney disease. A critical point to emphasize to your patient is that chronic kidney disease is a strong link to cardiovascular disease. In fact, most of chronic kidney disease patients tragically die of heart disease long before they ever reach end stage renal diseases. Our nutritional goal for the chronic kidney disease aim to slow this progression. So the medical nutrition therapy for the chronic kidney disease. In a chronic kidney disease, our primary medical nutrition therapy or NT goals are to manage symptoms, decrease the risk of progression, lower inflammation, and maintain a nutritional tone. Historically, severe protein restriction was used. The current, the current guidelines suggest that for the patient with a glomerular filtration rate lower than 25 who are not on dialysis, protein should be limited to zero point 0.6 gram per kilogram daily with 50% high biological protein value to prevent uremic symptoms. Energy should be around 35 kilocalorie per kilogram daily to spare that protein. Importantly, in diabetic patient, tight blood sugar control is far more effective at delaying renal failure than protein restriction. This is the scientific evidence. Minerals management is just as important as macronutrient. To control edema without causing dangerous hypotension, sodium is limited to about 1500 milligram daily. Potassium management is highly individualized. Many patients only need to restrict potassium late in stage 4 for the chronic kidney disease when urine output drops below 1 liter per day. Phosphorus should be restricted early down to 1000 milligram daily once glomerular filtration rate drops below 60 to delay secondary hyperparathyroidism and bone disease. Diets like DASH diet and Mediterranean diet are proving highly effective for managing these parameters. When chronic kidney disease progresses to its final stage, we reach end stage renal disease. End stage renal disease reflects the total inability of the kidneys to excrete waste, maintain fluids, or produce hormones. As nitrogenous waste build up to unacceptable levels, the patient develops a clinical syndrome called uremia. Symptoms include extreme malaise, nausea, muscle cramps, severe itching, and metallic taste in the mouth. Clinically, we generally see this occur when blood urea nitrogen exceed 100 milligram per deciliter and creatinine reach 10 to 12 milligram per deciliter. At this point, survival requires renal replacement therapy. When patient progressive from stage 4 to stage 5, treatment options are hemodialysis, peritoneal dialysis, kidney transplantation, or palliative medical management leading to death. Hemodialysis can be done in a clinic or at home, but carries risks like bleeding and sepsis. Peritoneal dialysis is managed by the patient at home, which offers lifestyle flexibility but carries risk of peritonitis and weight gain. Transplantation offers the fewest lifestyle limits but involves heavy immunosuppression. Let's look closer to hemodialysis. Hemodialysis requires permanent surgical access to the bloodstream, usually via arteriovenous fistula or artificial graft. The machine uses dialysate fluid to pull waste from the blood through diffusion, ultrafiltration, and osmosis. Standard outpatient hemodialysis required treatment of 3 times a week. We measure how well the dialysis is working using kinetic modeling, aiming for KTV per V greater than 1.4 or 1.2 by ensuring urea reduction ratio of at least 65%. Peritoneal dialysis takes different approach. Peritoneal dialysis uses the patient's own peritoneal membrane inside the abdomen as the filter. Surgical implanted catheter instills a dextrose-based dialysate. Waste diffuses into this fluid and water follow via osmosis. This can be done manually during the day, known as continuous ambulatory, or by a machine night called automated 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 dialysis. A major nutritional complication is that patients absorb 400 to 800 calories of dextrose from the dialysate every day, leading to unwanted weight gain. Because dialysis removes a nutrient as well as waste, our end stage renal disease protein goal shift dramatically. Dialysis is a massive drain on body protein. Hemodialysis patients lose about 15 gram per treatment. So they need 1.2 gram of protein per day for the kilogram per day. Peritoneal dialysis patient loses even more than 20 to 30 grams daily, requiring 1.2 to 1.5 gram per kilogram. In both cases, half must be high biological value protein. Energy need stay around 25 to 30 kilocalorie per kilogram depending on the nutritional status. This is incredibly difficult for the patient as uremia causes taste aberration, frequently making them unable to tolerate the smell or taste of red meat. To monitor this, we rely on a specific set of blood values. For end stage renal disease patient, normal looks different. Blood urea nitrogen 50 to 100 is perfectly acceptable. Low blood urea nitrogen might actually indicate dangerous muscle loss or poor intake. Regarding creatinine, under 5 and under 15 milligram per deciliter is standard and is controlled by the dialysis machine. Albumin is critical. We want it above 4 gram per deciliter as low albumin is tightly linked with high risk of death, though it is often more reflecting of inflammation or fluid overload than a pure nutrition. We also monitor the carbon dioxide as chronic acidosis exacerbate muscle and bone catabolism. Fluid and sodium are perhaps the hardest restriction for patients to follow. Regarding the fluid and sodium balance, sodium drives thirst, which drives fluid intake leading to edema and hypertension. The daily sodium goal is strict 1500 to 2000 milligram, meaning absolutely no salt in cooking or from convenience food. Fluid intake is usually capped at 750 ml plus whatever urine output the patient has left to ensure they gain less than 4% of their body weight between dialysis treatment. Remember that 500 to 800 ml of hidden fluid in solid food accounts for insensible water losses. So it is not counted in that 750 ml limit. Potassium is a matter of life and death in end stage renal disease. Potassium. Potassium limits are usually set at 60 to 80 milli equivalent, or roughly 2 to 3 gram per day, depending on residual urine output and dialysis frequency. High potassium causes severe muscle weakness and can stop the heart. We have to warn patients about hidden danger, like low sodium products that use potassium chloride as the salt substitutes. If potassium spikes unexpectedly, we must investigate non dietary causes like misdialysis, like GI bleeding, like severe acidosis, or massive trauma. Phosphorus management presents a unique dietary paradox. The phosphorus must be limited to 1200 milligram or less per day because the failing kidney cannot excrete it and dialysis is poor at removing it. So the paradox is that high protein foods our patients desperately need meats, need dairy, need beans, are naturally high in phosphorus. Worse, inorganic phosphate additives in processed food are 100% absorbed. Therefore, almost patient must take phosphate binders like calcium carbonate or sivilamers, which with every single meal and snack to bind the phosphorus in the gut despite the risk of severe constipation. Failure to control phosphorus lead to devastating bone disease. As the glomerular filtration rate drops, the kidney fail to activate vitamin D, causing gut calcium absorption to plummet. Simultaneously, retained phosphorus bind up free calcium. This triggers the parathyroid gland to oversecrete the parathyroid hormone, which pulls calcium directly out of the bone, causing osteitis fibrosa, cystica, or osteomalacia. If the calcium multiplied by phosphorus product exceeds 70, that mineral complex deposits into soft tissue and blood vessels, causing metastatic calcification. We treat this cascade aggressively with active vitamin D analogs and to suppress the parathyroid hormone. Let's look at another synthetic hormone we use, the EPO, erythropoietin. The severe anemia of end-stage renal disease is primarily due to the kidney's inability to produce erythropoietin. We treat this with synthetic erythropoietin, which drastically increases the red blood cells production. However, this rapid production drains iron stores so fast that oral iron is useless. Patients require IV, intravenous iron, to keep their ferritin level securely between 300 and 800 nanogram per ml. Regarding vitamins, water soluble vitamins and vitamin C are washed out during dialysis and must be supplemented, whereas fat soluble vitamins like vitamin A, vitamin E, and vitamin K are retained and should not be supplemented. Now we are going to summarize the chronic kidney disease and end stage renal disease. Also, we have three sections, like in the kidney stones: etiology, pathophysiology, and the management. Etiology, pathophysiology, and the management. Think of this graphic as clinical roadmap. It traces the journey of the kidney disease from its initial causes, etiology, throughout through what happens when the kidney fails, pathophysiology, and finally how we intervene to keep the patient alive and comfortable. This is the management. So let's start with the phase one etiology. Etiology, how it starts. The top, this is the top section of the chart, focuses on the chronic kidney disease, the gradual loss of the kidney function over time, and what triggers it. The root causes four main pathways lead to chronic kidney disease: diabetes mellitus, hypertension, glomerulonephritis, and other disease. Diabetes mellitus, high blood sugar act like sandpaper inside the delicate filters of the kidney, wearing them down over time. For the high blood pressure hypertension, excessive force scars and narrows the blood vessels in the kidneys, starving them to oxygen. For the glomerular nephritis, inflammation of the kidney filtering units, the glomeruli. The other disorders, this include genetic conditions like polycystic kidney disease or congenital anomalies in the birth defect. Early chronic kidney disease management. When a patient is diagnosed with chronic kidney disease, the goal is to slow down the damage. We approach this from two angles: medical management and the nutrition management. Medical management, we prioritize aggressive blood pressure and blood sugar control to halt further damage. We use immunosuppressant therapy if inflammation is the cause, because failing kidney stop producing essential hormones. We also started giving synthetic erythropoietin to prevent anemia, and also active vitamin D for bone health. For the nutrition management, the diet change to the, reduce the kidney workload. This means sodium restriction to manage blood pressure, possible protein restriction as a protein breakdown it creates nitrogenous waste, monitoring electrolyte balances using phosphate binders, and modifying the diet to decrease cardiac risk factor. Since kidney and heart health are deeply intertwined. The section number two, or phase number two, pathophysiology, what happens when it fails. When a chronic kidney disease progresses to the point of no return, it becomes end stage renal disease or total renal failure. The middle blue section illustrates the domino effect of this failure. The graphic divides the impact of end stage renal disease into three main pillars: inability to function, the kidneys can no longer perform their three fundamental jobs: excrete waste product, toxins build up in the bloodstream, maintain and electrolyte balance, the body retain water and dangerous levels of the minerals like potassium, produce hormones leading to severe anemia and weak bones. Uremia, because the kidney cannot filter waste, the patient developed uremia, literally meaning urine in the blood. This means uremia. This is unacceptable toxic level of nitrogenous waste like urea and creatinine circulating through the body. For the clinical symptoms, uremia and fluid overload cause cascade of systematic symptoms that the patient will actively feel malaise and weakness, nausea and vomiting, muscle cramps and itching, metallic taste in the mouth, and neurologic impairment. The final section for the management, how we treat end stage. There is end stage medical management and nutritional management. For the medical management, dialysis and kidney transplantation and immunosuppressant therapy, psychological support, also hormone replacement. For the nutrition management, for the nutrition management, uh, nutrition in the stage renal disease, highly precise balancing act with a specific goal: prevent nutrient deficiencies, control edema and serum electrolyte, prevent renal osteodystrophy, the bone disease, phosphate, also low phosphate diet and take phosphate binders, provide palatable and attractive diet. Nutrition supports and diabetic end-stage renal disease. About 45% of new dialysis patients have diabetes, requiring a delicate balance between carbohydrate control and renal restrictions. If patient cannot eat, standard enteral formulas are usually fine, provided we monitor electrolytes. For hemodialysis patient, we can use intradialytic parenteral nutrition, administering glucose, lipids, and amino acids straight into the venous side of the dialysis circuit. Peritoneal dialysis patient can use also intraperitoneal nutrition using dialysate built with amino acids instead of dextrose. Treating children with end-stage renal disease requires complete shift in priorities. Pediatric chronic kidney disease and end-stage renal disease. In pediatric chronic kidney disease, our absolute primary concern is promoting normal growth and development. Therefore, protein restriction is highly controversial and generally avoided due to the severe risk of stunting. Children need at least the standard dietary reference intakes for their age and often more. Gastrostomy. Gastrostomy tubes are frequently placed early to guarantee intake, and peritoneal dialysis is preferred over the hemodialysis because it allows us to liberalize their diet. Strict control of phosphorus and active vitamin D is mandatory to prevent bone growth failure. For many, transplantation is the ultimate goal. Medical nutrition therapy for transplantation. After kidney transplant, medical nutrition therapy focuses on managing the intense metabolic side effects of immunosuppressive drugs like corticosteroids and calcineurin inhibitors. These drugs cause protein catabolism, weight gain, osteoporosis, and hyperglycemia. For the first 6 weeks, patients need high protein diet, 1.2 to 1.5 gram per kilogram to heal, with strict sodium limits. Once stabilized, protein need drop, fluid intake is encouraged to 2 liters daily, and patients require calcium and phosphorus supplementation to counteract steroid induced bone loss. Finally, we must prepare our patients for the worst case scenarios. Emergency diets for dialysis patient. When distress knock out power of or water, dialysis patients are acutely vulnerable. We instruct them on an emergency diet plan designed for up to 5 days without a treatment. It is incredibly restrictive. Meat is limited to 100 grams daily, fluids to 1 to 2 cups, and potassium rich food are completely avoided. Extra calories must come from salt free fats and sugar. Patients must keep an emergency kit with distilled water, non perishable renal safe foods, and their phosphate binders. And for patients who can't or choose not to dialyze, we offer palliative care. What is the palliative care? Palliative care and conservative treatment. The decision to forego dialysis is emotional and deeply personal. For these patients, we provide conservative medical management. We use highly restricted, low protein, low sodium diet. The goal here is entirely symptoms management, minimizing shortness of breath and the physical pain of uremia. Palliative nutrition balances the patient's desire for specific foods with the need to mitigate suffering, prioritizing their quality of life above all else. Delivering all of this care is a massive team effort. Finally, in this part, we want to talk about the coordination of care and counseling. The nutritionist or registered dietitian nutritionist holds a federally mandated role on the end stage renal disease, interdisciplinary healthcare team working alongside nephrologists, nurses, and social workers. Dialysis patients survive an averages of 7 to 10 years, meaning we must build long term, trusting relationships. We are asking patients to implement complex, ever changing, restrictive diet every day for the rest of their lives. Empathy, motivational interviewing, and deep compassion are just as critical as knowing how to balance calcium phosphorus product. Thank you for your attention and see you in the next chapter. We will talk about the medical nutrition therapy for cancer. Thank you very much and goodbye.